So, all right, let's go through it. So let's talk about some of the key points. When we talk about, so Oliver's topic was to look at what the current research is telling us we should be doing in terms of the treatments that we're using for certain patients that come through the door. So the first thing that we looked at was our low back pain patients with or without sciatica. So we were looking at what the current evidence base is telling us we should and shouldn't be doing in the treatment of patients who come in with back pain who have or haven't got associated leg pain. So anyone out there who's had sciatica or who's had back pain, this is the stuff that we should and shouldn't be doing with you. So in terms of treatments then, let's go through it all. Like, what were the things that we definitely should be doing with these patients?
What we should be doing, we should be encouraging people to try and self-manage their condition, and their rationale and reasoning behind that is because people will get flare-ups of their back pain. Back pain is really common, and it occurs frequently and reoccurs very frequently once it does manifest. So having tools in place or having strategies in place for them to be able to deal with it when it does come up is essential. So rather than making people reliant on coming having
manual treatment,
clicking, cracking, twisting, anything like that, is making them more aware that you need to be doing some stretching exercise. You can manage this yourself fine if you need to come in every now and again for, as Kat calls it, a tune-up. But really what you need to be doing is encouraging people to take ownership of their condition and be able to move forward with it and not become what they call a fear avoidant, not build it up in your head.
Okay, so the first part of what we do is educating patients to be able to manage their symptoms themselves.
Yeah.
What else should we definitely be doing with these patients, our low back pain patients with or without leg pain?
So with or without leg pain, we should also, the evidence is saying we should do some exercise therapy. So we should be doing some strengthening, stretching exercise, getting them moving, getting them doing aerobic exercise as well, such as walking, getting people active generally. And it is important that they do some activity as opposed to just saying, oh well, I'm active anyway, I'm always out and about, I'm always on the run with the kids or whatever. You actually have to spend time at like that, doing a structured graduated walking program, getting more active, or doing a class-based exercise program, or even just taking your laptop, following on YouTube, doing your exercise class like Pilates or the likes of yoga. It doesn't have to necessarily be Pilates, but so some form of exercise.
That's a good point, and we have said this before on the channel. Like, what are the exercises you should be doing for back pain?
So again, it says stretching exercises, which would be kind of your yoga or your Pilates. Strengthening exercises, which again would be a little bit more your Pilates, or it could be the likes of weight training and things like that. It said mobilizing exercises, which again is similar to your yoga. And then the aerobic exercises could be cycling, could be walking, swimming, anything like that.
What's another way of saying that?
What's another way of saying?
So what I'm getting at here is that it doesn't really matter, does it? Like, as long as we're getting them to do something.
As long as they're increasing their activity levels. And as I said, it's important that they're not just flippant with it and saying that, well, I'm always moving anyway, I'm always up and down, I never sit down, I never rest. You actually have to take time out of your day and do some activity. Yeah. That's the main thing. So exercise, self-management. The other thing is manual treatment, and they say it can be used in combination. So manual treatment alone is not recommended, but it has to come in combination with some exercise therapy as well.
So that's really important, and that's the thing. We will, like, okay, fine, you'll come in and we'll do some manual treatment, but if you do not do the exercises we're giving you for home, then we're being told by the studies that you're less likely to get improvements in your back pain. And I know we're harping on about this all the time, but it is so important that you do those exercises we give you for home. It's a manual treatment with the exercises. If you do manual treatment alone, or if you're not a physio patient, if you were getting care outside with other healthcare professionals, if you were just getting manual treatment, then you're not getting evidence-based care. The active treatment has to be a part of it. Is that a fair comment?
Mm-hmm.
All right, and we would absolutely make sure that everyone that's working at Physio has got their back pain patients doing some type of activity. Now, if you come in absolute agony and we're struggling to give you something, we'll send you straight back to the GP to consider medication so that we can get you doing the exercises.
Yeah.
Stresses me out. You should always have an active component to your treatment. The passive components alone are just not good enough. You can't be a passive person in your back pain. You've got to manage it actively.
Yeah.
Okay, what should we not be doing with our back pain patients?
So this was interesting. So in the report it said that we shouldn't be prescribing orthotics, which we don't do anyway.
No.
But again, it's nice to have it there in black and white saying that for back pain alone or back pain with your sciatica, your leg pain, we shouldn't be routinely giving you orthotics to try and treat your back.
Alone, like, you know, because again, there'll be patients out there that have come to us that have spent hundreds of euro on these fancy orthotics because they were told that it would improve their back pain. But again, if we look back at the research, if you're putting in those orthotics and that's the only thing that you're doing for your back pain, it's unlikely it's going to make a major significant difference long term. So again, all of this is the National Institute for Health and Care Excellence, these guidelines that we're talking about. And we'll link them, or if anybody's interested in reading the actual guideline, just send us a private message and we'll send you the link to the copy. It's open access, you can read through it. Because I know that's controversial, because people out there would have bought their orthotics and said that really helped my back pain. And like, there is probably cases where that is true, but we have to look at what these control trials are telling us to guide our best practice. What else should we not be doing?
Yeah, so it also suggests that we shouldn't be using corsets, braces, or things like that
Now
to try and
that's
help.
really controversial, isn't it? Because lots of our patients come in loving their belts for their back pain and wanting their back supports.
I guess if you want to break it down a little bit further, it's giving you the feeling of support, but what it can actually do is that it's stiffening up your back effectively. It's going to hold you a little bit more rigid, which just allows your muscles to stiffen up and become tighter and encourages that spasm, which we often see with people that are suffering with back pain. So that can just feed into that whole system. Whereas really what we want to try and do is we want to try and normalize your movement as soon as possible with your back pain. So we're trying to stop you moving in those altered patterns that you would classically see when someone is suffering with back. They tend to brace themselves when they're getting up out of a chair and things like that. So we're trying to get them to relax their muscles and then stand up or bend forward normally. And it will be a little bit sore.
Passive and active again, isn't it? Like, a belt is a passive treatment, and you become reliant on it.
Well, that's the other issue then, is so your muscles around the area aren't doing what they're supposed to do. They become a little bit weakened and a little bit relaxed. So again, you're passive on that, and then gradually over time you can become completely dependent on it.
And I know there's probably people out there watching, or even that are watching this video on replay, which will put up a message saying, you know, I couldn't manage my flare-ups without my back belt.
I still get people in they will come in and take their brace off, for treatment. And again, it's about educating them, but that's fine. Sometimes people just have, and they get that relief from it, and that's fine.
It's their go-to. It's nearly like
a crutch.
A crutch, yeah, exactly. And look, we're not going to strip that belt off someone if they come with it on. What we're going to do is try and get them to improve their strength around their hips, around their back, so that they can feel that they've got the strength to support their back and aren't relying on that belt. Now, just a slight note in here, if you are pregnant and you have got back pain, then that's a separate set of guidelines. And there is evidence there to say that if you are pregnant and you've got back pain, that a belt can help reduce symptoms to get you through your pregnancy. So that's just important to note. Pregnancy related back pain and belts, it does ease symptoms. But that's completely different, because when you're pregnant, the hormones are relaxing the ligaments that are stabilizing around your back. So that bit of stability does help reduce pain and support the weight. That is separate from someone who's not pregnant with back pain. The belts really are not evidence-based care, and we shouldn't be prescribing them. What else shouldn't we be doing?
We shouldn't be treating back pain alone with just paracetamol. So paracetamol by itself, just taking it for your back pain, is ineffective, basically, is what the research is saying. So again, sometimes GPs give you paracetamol along with some anti-inflammatories sometimes, or they'll give it to you with if you've got that sciatica, that leg pain, they'll give you neurogenic pain relief, or neuropathic pain relief, sorry. And again, you can take it with exercise again, so you're not becoming reliant on that paracetamol, but effectively the research is saying that paracetamol by itself won't have much of an effect.
So let's talk about the medication. Now, just disclaimer here, neither Ollie and I are pharmacists and we're not GPs.
No.
All we're doing is repeating what is in these nice guidelines about the pharmaceutical management of back pain. So if you have any questions about it, again, we'll send you the guideline.
Good.
If
And
they've got...
just on another side note, so when someone does come into our clinic, what we will have the discussion with them about what might be suitable for them. But again, it's not up to us to make that decision. We would say, look, I think this is what you need to speak to your pharmacist about. If it is your NSAIDs over the counter that they can get, or like that, if it's something that they need prescribed, we might sometimes give them a letter to take to their doctor and have that discussion with their GP and see what is appropriate for them. But it's giving them that tool to start that conversation with the appropriate healthcare professional to guide them in the right direction.
Because if you're taking other medications or you've got other health conditions, you need to be careful about what medication you're taking. So you need to check with the professionals there. But just as sort of a brief run through, so if somebody is just having back pain, no leg pain, what are these guidelines telling us in terms of medication?
Again, as long as it's safe to do so, non-steroidal anti-inflammatories are what's recommended in a short course. Short as possible is what the guidelines say, and in the smallest treatment dose possible, smallest effective treatment dose possible for their back pain to get it under control. And you can take that with the paracetamol as well, is what it says.
And then if they've got leg pain?
If they've got leg pain, it's more of your neuropathic pain relief. So that would be your Lyrica, your gabapentin, things like that, your amitriptyline. Would be what you would need to take. Again, you would have to go to your GP to get that prescribed.
So
and generally what happens is the GP starts you off on a small dose to make sure it agrees with you, because there can be some side effects to it, and then they gradually titrate it up, they gradually increase the dosage until it becomes effective. But what the research is saying is, with these neuropathic pain relief, if it isn't effective, you can trial up to about 3 different types. So there's a few different types that can work, and one doesn't always work with everyone. So you have to mix them around and see what one works for you.
And I think sometimes we see in clinic the patients come in with leg symptoms, and actually, to be fair, the GPs have upped their pain relief. They've given them things like tramadol, diphenhydramine, even things like Valium, but they haven't given that mix of the neuropathic medication. And whereas we would then look at the guidelines and actually say, is it worth going back to have a discussion with the GP whether we, look at adding a neurogenic medication for somebody who's got those arm and leg symptoms. So again, it's not our area of expertise, but we're looking at what the guidelines are saying and then working in conjunction with other healthcare professionals. Because let me tell you something, if you come into us and you're in a lot of pain, we have to start getting you doing active treatment. That's what the guidelines are saying. And if you can't because you're in so much pain, then we have to go through a short course of pain relief to bring it down. And can I tell you, some patients hate going on pain relief, but it works short term to get you moving.
I would say a lot of patients come in and say they don't like taking pain relief, and they don't like taking anything if they can get away with it, and that's absolutely fine. I'm the same myself. I don't like taking a headache tablet if I can do without. I'll put up with the pain, but ultimately, if you're in a catch-22, you're sore, but we need to get you moving. You can't move because you're too sore, so then you're in that position. So what we do then is we have a discussion with your GP, get some pain relief on board for a short period. It's not a lot. It's not the answer. It's not going to cure your back. What it's going to do is it's going to bring your levels down. It's not going to get rid of the pain completely, but it's going to bring the pain levels down to allow you to engage in a little bit more movement and normalize that movement. And that's effectively what's going to start to get your back better. And then once that movement is starting to come back, we can then get you to start to wean off the medication.
I think the last point about back pain, probably about seeking help to prevent long-term back pain. I think that's probably the last point, isn't it? So the guidelines, the old thesis on it used to be most back pain resolves within 6 weeks. So then GPs or even patients would only come and seek help when it's been going on for a while. But in the newer guidelines, it's saying actually...
Yeah, so it's saying that if someone gets back pain, they're at risk of developing, they call it high risk or poor outcomes at any stage of that process of having back pain. Whereas as Ciara mentioned, the previous guidelines said it was in the first 6 weeks, the majority of the pain settles down, and then if they still have pain after 6 weeks, then they're at risk of having that persistent low back pain. But in actual fact, the new guidelines have come out now and said, look, if you have back pain, you're better off getting it seen to or getting it addressed by a healthcare professional. They can give you the right information. They can give you the tools or the self-management strategy. As I said, it's not necessarily that you need to come in for a course of treatment or anything.
There's no
it's been given the advice, it's been given the tools, the exercises, and the reassurance is big. That helps to drive that pain down and gets you moving as soon as possible. And really, that's what helps to drive that pain down and get that back pain out of the picture as soon as possible.
Okay. Whew.
Jeez, that was only one topic. So we covered back pain, we covered shoulders, knees, and we covered electrotherapy
hamstring
today.
rehab.
On
We did lots.
Hamstring rehab.
Yeah.
So we did loads. So that was just a snippet.
Just a snippet of what we did. But I think a lot of people suffer from back pain, so hopefully you have that information is helpful. If you're watching this and you know anyone or any members of your family have back pain, just let them know that those tips are there and they might find them helpful. I think the overall message is that activity is key. But if you're in any doubt, get it checked out.